Welcome to Say the Question. I'm Joe, here with Sam, and today we're asking why the same prescription can hit you like a totally different product, depending on your insurance, coupons, and whatever the pharmacy can process. That's the hook. Same medicine, wildly different bill.
Yeah, because the awkward part is that there often isn't one clean price to point at. KFF notes that list prices do not account for rebates or other concessions, so the number you see is not always the number that actually drives what you pay.
Right, and that's exactly why this deserves a real look instead of a shrug. So let's start with the boring definition first, because once you separate sticker price from the price that actually lands on you, the whole thing gets a lot less magical. Sam, start us off.
Okay, here's the annoying part. The exact same prescription can feel like 3 different products depending on insurance, a coupon, or which pharmacy ends up processing it. Same pill, different emotional damage.
And that's the clean version of the complaint. The patient isn't comparing one neat price to another neat price. They're getting whatever number falls out of a stack of rules, contracts, and processing choices.
Which is why it feels fake. You don't buy the pill, you buy the version of the pill that made it through the paperwork.
That's the better way to say it. And to be careful, that doesn't automatically mean fraud. It means the system is built so the number you see is not a simple sticker price.
But come on, Joe, if a prescription can be cheap here and weirdly expensive there, or covered one way and not another, what part of that still sounds like a normal consumer market to you?
Not much of it. Even the broad data point is that many prescriptions do have out-of-pocket costs, and those amounts vary a lot by drug type. So the patient-facing price is already not one fixed number attached to the medicine.
That's the thing people run into at the counter. Same medicine, different day, different insurance setup, different person at the register, and suddenly the price changes like it woke up moody.
And sometimes, even the same drug can surface multiple patient-facing prices depending on the channel. Eliquis is a clean example. A discounted, direct-to-consumer cash price can still be different from Medicare's negotiated price, which tells you the pathway matters almost as much as the molecule.
So the suspicion isn't, I found one crooked pharmacist in a dim alley. The suspicion is that the whole setup makes the consumer absorb confusion, while everybody else up the chain understands the rules.
Mostly, yes. That's the fair version of it. Whoever can write the contract, set the formulary, or choose the processing path has more power than the person standing there with a prescription and a debit card.
And the part that bugs me is that the patient usually has to ask first. You don't get a neat answer like, here's the real price. You get a number, then a different number, then maybe a coupon, then another number after the claim runs.
That mismatch matters. If the price depends on which pathway gets used, then the relevant question is not just, what does the drug cost? It's, who gets to choose the pathway and who gets stuck dealing with the fallout?
Right, and ordinary people feel that at the pharmacy counter in a very specific way. One day the clerk runs insurance first, the next day they try a coupon, and sometimes they tell you cash is better, like the whole thing is improv with a hostage situation built in.
That part is especially maddening because it turns a basic question, what do I owe, into a little negotiation nobody asked to join. The system doesn't just give you a price. It makes you test 3 different doors to find out which one opens.
And that's where people start getting suspicious in a reasonable way. Not the pharmacies are secretly cackling, but why does the answer seem to depend on who touches the claim first?
That's the real pressure point. If one person runs it one way and gets one number, and another person runs it a slightly different way and gets another number, then the patient isn't really dealing with a price. They're dealing with a process.
And processes are where people hide things without necessarily breaking a law. You can make something feel opaque, exhausting, and impossible to compare and still stay technically inside the rules.
Exactly. That's why the right suspicion is not every price difference is proof of a scam. The right suspicion is if the price is this hard to see, who benefits from the confusion and who pays for it?
And I do think that question matters because confusion is not neutral. If the person paying can't easily tell whether insurance, a coupon, or a different pharmacy would change the number, they are already negotiating from the worst possible position.
Right, and that doesn't require a cartoon villain. It just means the system rewards the people who can see across the whole chain, while everyone else is left guessing at the edge of it.
So the starting complaint is simple. The same prescription can land on the patient as 3 different experiences, and none of them feels like a real, honest price until you already have it in your hand.
That's the complaint worth taking seriously. Not because every messy price is suspicious on its own, but because the opacity itself is doing work. And the next question is, who gets to live with that work?
People don't distrust this because they're being dramatic. They distrust it because the number shows up when it's too late to do anything about it.
Okay, but before we call it shady, let's separate what feels shady from what is just hidden. Those are not the same thing, even if they land in the same miserable place for the patient.
Fair. Hidden is the polite word. You show up with a prescription and the price is basically not in the conversation yet.
And that is exactly why people get prickly. The surprise isn't only that it costs money, it's that the system waits until you're already there to tell you what the money is.
Ugh, which is a nasty little moment. You came in expecting a medical errand and got a price reveal after you committed time, energy, and probably the hope that this would be simple.
Right, and that emotional whiplash matters. A lot of people are not just annoyed by the amount, they're annoyed by the sequence. First the need, then the processing, then the number, then the panic. A lot of the time, the price only becomes clear after the prescription is processed. And for some plans, the amount can depend on the price used in the calculation.
Which the patient never saw in the first place.
Exactly. So the suspicion isn't random paranoia. It's a rational reaction to being asked to pay first and understand later. That order of operations is doing a lot of damage all by itself.
And then you get the whiplash of a simple errand turning into a tiny negotiation. Same drug, same store, and suddenly insurance rules, coupon programs, and what the pharmacy can process decide whether the visit is annoying or brutal.
That unevenness is a big reason people think something is off. If the same prescription can land differently depending on layered rules nobody can see, it feels less like pricing and more like a process built to keep the patient guessing.
And the worst part is you can't really test it in the moment. You can't compare 5 versions of the price while you're standing there feeling sick and trying not to hold up the line.
No. And you usually can't contest it cleanly either. You can ask questions, but if the number depends on hidden processing rules, the patient is stuck trying to reverse engineer a system they don't control.
Joe, am I overstating it if I say the real problem isn't just high prices? It's that patients can't compare or contest them in any meaningful way?
No, that's the stronger version. The CDC data says about 70% of prescriptions have an out-of-pocket cost. And people respond by asking for cheaper options or sometimes not taking medication as prescribed.
So this isn't some rare corner case where one unlucky person gets burned. It's common enough that people are building workarounds at the point where they should be getting help.
That's the part people skip. When a KFFFAQ has to explain that some Part D enrollees can spread out-of-pocket costs through the year, instead of paying them all at once at the pharmacy. That tells you the upfront hit is a real pressure point.
Right, because nobody's writing a workaround for a trivial inconvenience. They're doing it because the pharmacy counter is where the cost becomes immediate and stressful.
Exactly. The distrust sticks because the system doesn't just charge people. It hides the terms until the moment they have the least leverage.
So the fair standard isn't patients should just be less suspicious. It's show the real number earlier, make the rules legible, and let people understand the charge before the moment has already passed.
And if you want the cleaner version of the complaint, that's it. Not every surprise is fraud, but a system that only becomes legible after the bill arrives is asking for distrust.
Okay, before we keep arguing about whether this whole thing is ridiculous, we should separate the words people toss around like they all mean the same thing. Because they really don't, and that confusion is doing a lot of work here.
That's the useful starting point. The big one is list price versus negotiated price. List price is basically the sticker number, and it does not take into account rebates or other price concessions. Negotiated price is the amount a plan and manufacturer agree on for coverage purposes.
So the first number people hear is often not the number that matters most. Great. Nothing says simple healthcare like having a first answer and then a second answer that actually counts.
I would not call it fake exactly. It is still a real price in the system, just not the one most patients should use to figure out what they personally owe. That's where the other pieces come in: copay, deductible, and sometimes coinsurance.
Okay, so break those down like I'm standing at the pharmacy and my brain is already melting. What's the copay in plain English?
Copay is the fixed amount your plan can make you pay for a drug, often tied to the drug tier or plan design. Deductible is the amount you may have to pay out of pocket before the plan starts sharing more of the cost. Coinsurance is the percentage split, where you pay a share instead of a flat number.
So the same prescription can feel cheap, annoying, or absurd, depending on whether you've met your deductible and whether the plan says flat copay or percentage share. That's not one price. That's 3 different games in a trench coat.
I was going to avoid the trench coat thing, but unfortunately, yes. The same drug can land very differently depending on the rule being applied. And that's why people get mad. They're not imagining the inconsistency. The system can change the answer by changing which number it uses.
So when somebody says, my prescription was $30, that might mean their copay. When somebody else says, mine was $200, that might mean they were still chewing through a deductible. Same drug, different rule book.
Exactly. And one more wrinkle. Sometimes the same drug looks different because a negotiated price replaces the list price in a coinsurance calculation, which can lower what the patient pays. So if you do not know which number the plan is using, the quote is almost meaningless as a comparison.
So the patient isn't really comparing one drug price to another. They're comparing the plan's rules wrapped around the drug price.
That's closer. A flat copay gives you one kind of predictability, while deductible and coinsurance leave more of the bill exposed to the plan's math. The drug itself hasn't changed, but the billing path has, and from the patient side, that path is basically the product.
Give me the boring example. 2 people pick up the same prescription, but one plan has them on a flat copay and the other has them still working through a deductible. That's the same medicine, but not the same experience.
Exactly. And if the second plan uses coinsurance, the amount can move again because the percentage is applied to whatever price the plan recognizes. So the patient isn't making up the chaos. The rules are producing it.
Then the coupon side piles on top of that, which is where people start feeling like they need a spreadsheet and a hobby just to get treated. How is that different from insurance pricing?
Manufacturer assistance programs and cost-sharing assistance programs are separate from the plan's own pricing. They can help bring the out-of-pocket amount down, sometimes even for insured people. But whether they can be used depends on the rules around the drug and the claim. So it's not the same as the insurance price, even when it ends up changing what the patient owes.
So one person gets a coupon accepted, another gets blocked, and the pharmacy is stuck in the middle, translating between systems it didn't build. That is the part that feels absurd to normal people.
That's the messenger, not the author problem. And once you can name the moving parts, the next question is, who built the pricing system that makes ordinary people do this much decoding just to find out what a medication costs?
Okay, so the obvious next question is how you end up with this many layers in the first place. Nobody wakes up and says, let's make a prescription price need 3 translations and a coupon to be readable.
No, but the system got there by accretion, not by elegance. Ingredient cost, dispensing fees, rebates, negotiation, all of that got stacked onto older arrangements instead of being redesigned from scratch.
Which is already kind of the nightmare version of boring. Not a mastermind, just a pile-up. And once you have a pile-up, the person standing at the pharmacy counter is the one who gets asked to absorb it.
That's the useful distinction. It can be opaque without being a single grand plot. A lot of this is old contracts, old rules, and then new workarounds pasted over the top because the first fix created a second problem.
So the history isn't one bad decision, it's a lot of smaller ones that never got unwound. That feels very on brand for healthcare. Everybody agrees the wiring is ugly, and then somehow the ugly wiring becomes the thing people depend on.
Exactly. Once a system touches insurers, pharmacies, manufacturers, and patients, changing it stops being a clean edit. Each group has some reason to keep the current structure, even if they complain about it in public.
Joe, am I overstating it if I say the layering itself starts to become the business model? Because that is where it stops sounding like mere inconvenience and starts sounding like a machine that runs on confusion.
Not overstating if you keep the claim narrow. The layering creates room for negotiation, and negotiation creates room for different prices depending on who is paying, who is processing, and which rule set is being used that day. That's not proof of bad intent. It's proof of a system that rewards complexity.
And the patient didn't choose any of it. They just show up with a prescription and get told, actually, this one is covered if you use this card, this one if the pharmacy processes it a different way, and this third one if the coupon gods are feeling generous.
Right, and that's the part the history explains. The system grew around negotiated payment layers, not around a patient standing there asking for one honest number. Once the structure is built that way, the confusion isn't an accident at the edges. It's part of the operating shape.
And that's why people keep asking why it can't just be fixed. Because every fix lands on top of another fix, and somebody downstream gets annoyed. Not a glamorous answer, but it is a real one.
It also helps explain why big spending categories keep getting patched instead of reset. Retail prescription drugs have been a major part of health spending for a long time. So the politics and the contracts keep reacting to the mess instead of wiping it clean.
So the history isn't some neat origin story. It's a long series of compromises that got frozen in place because too many people were already building around them.
That's the part people skip. Old systems are often hardest to change after everyone depends on them. Even when everyone admits they are annoying, the annoyance isn't enough to overcome the cost of moving all the pieces at once.
And that is where the later reforms tell on the original design a little bit. When you have to add protections like annual caps or ways to spread costs over the year, you're admitting the earlier structure put too much burden in the wrong place.
Yes, those fixes are basically the system saying, okay, that hurt too many people, let's put a handrail on it. Which is better than nothing, obviously, but it also shows the original setup was asking ordinary people to absorb too much risk up front.
So the fair summary is, this mess wasn't born evil, it was accumulated. A fairer design would let the patient see one understandable price before they commit, even if the billing machinery still has to sort itself out behind the scenes.
Yeah, and that's the bridge to the next question. If the weirdness is layered history, then the real issue is who benefits from leaving those layers in place, and who pays every time the system stays hard to read.
Okay, but after the history, the next question is, who has a reason to keep this thing hard to read? Because the patient is definitely not the one cashing in on the confusion.
That's the right place to look. Not for a cartoon villain, but for the people who get leverage from the mess, or at least don't lose enough to fix it fast.
So the first answer is the middlemen, right? If the pricing is layered enough, somebody in the middle can steer volume, negotiate terms, and make the whole thing harder to challenge.
That's the clean version of it. KFF's overview of PBMs points to concentration and vertical integration, which can let them steer people toward preferred pharmacies and, in some cases, give affiliated pharmacies better reimbursement or more contractual pressure than outsiders.
So complexity isn't just a bug, it's also leverage. Joe, am I overstating it if I say the ugly part is part of the business model here?
Not if you say it carefully. I'd put it this way. Some complexity is just the result of a messy system. But opaque complexity can absolutely protect position. It makes it easier to keep advantages that are hard for patients to see, compare, or fight.
That's fair. And once you see that, it's hard not to notice how many people can live with the mess as long as they're not the one paying to clean it up.
Exactly. The insurer, the PBM, the pharmacy, the employer or plan sponsor, and the network arrangements inside bigger systems all sit in a structure where one person's transparency can become another person's lost bargaining power. Nobody has to be evil for that to matter.
Right, and that's what makes it feel so sticky. If one side simplifies first, they may just hand over leverage while everybody else keeps the same habits and the same contracts.
That's the part people miss. Everyone can hate the system and still behave as if the system is somebody else's problem. So the incentive is to complain about opacity while relying on it.
Which means nobody wants to be the first person to eat the cost of clarity. Less opacity means less room to steer, less room to extract margin, and less room to hide behind a contract nobody can read without a headache.
And the Medicare and Medicaid side makes that even more obvious, because KFF describes PBMs doing financial and clinical services, while managed care organizations may contract with them to negotiate individual pharmacy rates instead of using one set payment rate.
So the patient is staring at the final number while a bunch of negotiations already happened somewhere else. That's where the irritation comes from. Not just the price, but the sense that nobody can tell you who said it and why.
And when people can't make sense of the price, they don't usually solve the system. They work around it. The CDC notes people use cost-saving strategies when prescriptions are expensive, which tells you who absorbs the friction when the structure stays confusing.
That's the part that feels backwards. The industry gets to keep the machine complicated, and the customer becomes the unpaid operations department, trying coupons, switching pharmacies, or just hoping the next checkout is less humiliating.
And even plan design can bake in different experiences before anyone talks about the drug itself. KFF's Part D analysis notes that cost sharing can vary by tier and by whether a drug uses copay or coinsurance. So the same prescription can land very differently depending on the structure around it.
So if we're being fair, the standard isn't that everybody should magically agree on one simple price. It's more like, can a normal person tell who benefits, who pays, and what choices are actually real?
Yeah, and if the answer is no, that's not proof of a scheme. It's proof the design is protecting itself, which is why the money trail matters next. Because once you follow who gets paid and when, the fog gets a lot less polite.
Okay, so if the incentives are clear, the next question is the actual cash path. Who gets paid, who gets squeezed, and where does the number change hands?
That's the annoying part. There isn't one price. There's the price on the label, the negotiated price, the pharmacy's reimbursement, and then whatever the patient is told at the counter. Those are related, but they are not the same thing.
Which is why it feels like every part of the process is hiding a different number. Not necessarily a secret, just a lot of places where the real number can disappear.
Pretty much. PBMs sit in that payment chain too. They're part of prescription pricing and payment, and rebates can lower plan costs and may translate into lower out-of-pocket costs for patients at the point of sale. But that doesn't mean the patient sees the full path. It just means another layer is affecting the outcome.
So who actually has leverage here then? The insurer, the PBM, or the pharmacy? And, more to the point, which one gets to act like the other guys made the decision?
All three, in different ways. The pharmacy often doesn't control the final number it shows because its reimbursement is shaped by insurer contracts and PBM rules. And that can be very different from the sticker price a customer sees. So the person at the counter is usually not the person who set the number.
That's such a classic setup. The place you can walk into is not the place where the price is really decided. You can complain there, but they are basically holding the receipt for somebody else's math.
Exactly. And once you add negotiated prices on one side and patient cost sharing on the other, the whole thing gets slippery. In some settings, the patient's share can still be tied to a list price rather than the negotiated one, which means the visible bill can come from a pricing step the patient never gets to see.
So the counter price is not just the price, it's the result of a bunch of private deals colliding in public. That's a lovely little customer experience there.
Yeah, and that's why people get tripped up when they compare what one person pays with what another person pays. The system can route the same prescription through different contracts, different benefit rules, and different sharing arrangements. So two patients can end up with very different bills without there being a neat, simple answer like, the drug is worth exactly this.
And then coupons or manufacturer assistance come in and make it even harder to read. One person gets help, another person doesn't. And suddenly the cheap prices may be real for that patient, but totally useless as a guide to what the market is doing.
That's the part people skip. Manufacturer patient assistance and cost-sharing programs can lower what one person pays, sometimes a lot. But that doesn't magically reveal the underlying market price. It just changes that person's route through the system. Helpful at the counter, not a clean window into the whole thing.
So if I'm being fair, the coupon isn't fake, and the savings aren't fake. It's just that the savings are local. They're about what this one patient pays, not about whether the whole pricing structure makes any damn sense.
That's the clean version. And if the system were fairer, the patient would get the likely out-of-pocket number up front, plus a plain explanation of whether that number came from a negotiated rate, a PBM rule, or a coupon detour. Right now, the patient is mostly seeing the last step of a much bigger transaction chain.
Okay, so here's the polite version people reach for. Prescription pricing is individualized, tied to coverage, negotiated behind the scenes, and different for different people. Which sounds rational until you remember the person at the counter isn't trying to admire the architecture. They're trying to find out if they can afford the pill today.
That's the clean story. And to be fair, it's not invented out of thin air. Plans, pharmacies, list prices, negotiated prices, co-pays, co-insurance, all of that can feed into the final number. The problem is that the final number isn't a universal sticker price. It's the result of a pathway most patients don't control or even see.
And that is the part people soften when they talk nicely about the system. They say, coverage changes the price, which is technically true, but it leaves out the emotional experience. You asked for medicine and got a scavenger hunt. One person pays one thing, another pays something else, and nobody at the counter can explain why in a way that feels human.
Yeah, there can be real structure there without it being legible. Think of it like a machine with a lot of gears. The gears are real, but the display panel is useless. Patients don't experience efficient negotiation. They experience surprise, delay, and the feeling that the number is being generated somewhere else by someone else's rules.
Which is why the polite answer always sounds like it was written by somebody who has never stood there with a bag of prescriptions and a dead-eyed pharmacist saying, "That'll be this much." The official language is individualized or plan-based. The lived language is, "I need a spreadsheet and maybe a priest."
The interesting thing is that the system can be orderly and still be opaque. KFF's point about Medicare negotiation is useful here. List prices can still matter in out-of-pocket calculations and plan.
Design can swing things between copays and coinsurance. And once you admit the number can come from different places, the phrase "the price" stops meaning what normal people think it means.
Exactly. The price is doing too much work. Sometimes it's a negotiated number, sometimes it's a plan-specific number, sometimes it's the amount the pharmacy can actually process, and the patient is expected to treat all of that as if it's one coherent thing. That's where the system starts sounding sane on paper and absurd in practice.
So the dishonest move isn't always "we're charging you extra because ha-ha." It's more often, "we built a maze and then acted like the maze is just how prices naturally are." That's less cinematic, but honestly more useful. The problem is not only that the answer is hard, it's that the hardness gets dumped on the least equipped person in the room.
That's the fairer version of the complaint. It doesn't require a secret villain, and it doesn't require pretending every confusing bill is proof of fraud. It says the system can be real, contractual, and still wildly unfriendly to patients because the information and leverage are distributed badly.
Let me push that one step further, though. If individualized really just means different because the rules are different and the patient can't see the rules, then that's not personalized in the warm customer service sense. It's personalized in the annoying sense, where the burden gets customized onto you. Joe, where would you draw the line between complicated and basically unfair?
I draw it at visibility and recourse. If the number changes because your plan genuinely works differently, fine. But The patient should be able to see why before they're stuck at the counter, and they should have some real way to challenge or compare it without needing a decoder ring. Once the system requires insider knowledge just to know what you're paying, the "it's individualized" line starts sounding like a nicer way to say, good luck.
Okay, but before we keep treating this like the pharmacy is making up numbers out of spite, we should clean up the easiest bad take. People hear a high price, then a coupon, then a lower number, and they go straight to, so which one is the real one?
And the annoying answer is that there usually isn't one single number that does all the work. A drug can have a list price, a negotiated price, and an out-of-pocket price. And those are different because they describe different parts of the transaction. One of those is what gets printed somewhere, one is what a payer agrees to, and one is what the patient actually feels at the counter.
So the first dumb version of the argument is treating the whole thing like there's a single sticker price sitting under all this nonsense. Like somebody is hiding the one true number in a desk drawer and everyone else is just acting busy around it.
That's closer to the problem than the conspiracy version, but it still misses the structure. Do you think people are really reacting to the number itself, or to the fact that the number changes depending on who is paying and who has leverage?
Mostly the second one. Because if you're standing there, you don't experience this as a neat pricing theory. You experience it as, why did my medicine cost this yesterday, that today, and something else if I said the right word to the pharmacist? That's where people get suspicious. Not because they're stupid, but because the system makes the answer feel conditional and annoying.
Right, and that suspicion is fair. The cleaner version of it is not everything is fake. It's this system has multiple prices attached to it, and the patient is usually the last person to understand which one is being used. Coupons and assistance programs fit into that mess too, because a coupon can reduce what the patient owes without being the same thing as the underlying insurance price. That distinction matters even when it feels like bureaucratic hair splitting.
Which is why the word discount can be doing a lot of work it hasn't earned.
Yeah, for the patient, it may still be a real savings, and I don't want to hand wave that away. If your bill goes down, your bill goes down. But that doesn't automatically mean the drug now has one lower true price for everyone. It can mean the patient's share changed, or the timing changed, or the program changed how the cost is split up. The headline number and the lived number are not always the same thing.
And that's where people overcorrect. They hear not one price and jump all the way to, so nothing is real. But that's not the better answer either. The bill is real. The frustration is real. What's fake is the fantasy that ordinary people can easily see through the whole pricing stack and tell whether they're getting a clean deal.
Exactly. The system can be real and still be opaque enough to feel hostile. A lot of the trouble comes from the fact that the patient may see one number at the counter while the insurer, the pharmacy, or an assistance program is operating on a different one in the background. That doesn't make every confusing price malicious, but it does mean the design asks a lot of the person with the least power to verify it.
So the fair complaint is not, there must be one pure price and everyone's lying. It's more like the system keeps asking the patient to decode a set of prices they never got to negotiate. And then it acts surprised when people assume the worst. Joe, is there any version of that where you'd say, no, that's not just confusing, that's actually misleading?
I'd say misleading is the right word, when the offer or the process makes people think they're getting a normal markdown and they're really dealing with a separate assistance mechanism or a different payment setup. That's not the same as saying every case is a lie. It's worse and narrower than that. The structure can be real, but the way it's presented can still keep people from understanding what they're agreeing to. So, if we're being fair, the question is who benefits, who pays first, and who absorbs the confusion?
Okay, but before we keep staring at the smoke, let's slow it down. This system is weird and suspicious is a real complaint. We've proved a secret room full of villains is a different claim.
That's the line, yeah. A system can be messy, concentrated, and hard to challenge without anyone having to orchestrate every ugly outcome.
Which is maddening because the brain wants a named villain. It wants a guy in a blazer explaining the whole thing to a whiteboard. And obviously, that image is too satisfying to be trustworthy.
And that instinct is exactly where people can overreach. The fair question is, who has leverage? Who benefits from the confusion? And who gets stuck paying for it?
So the fair suspicion is structure, not masterminds.
Mostly. KFF's PBM overview gets at that. Concentration, vertical integration, steering, contract leverage. Those are structural features that can produce opaque results even before you prove direct coordination, which is the annoying part because the mess looks smarter than it is.
And I hate that sounds boring because it is also basically the answer. The system can be ugly for boring reasons. And boring reasons are usually the ones with the most paperwork attached.
Unfortunately, yes. Boring is often what the real explanation looks like. It doesn't excuse the mess, but it does keep us from turning every bad incentive into a spy novel.
Joe, am I overstating it when I say the system practically trains people to think conspiratorially? Not because the patients are gullible, but because the whole thing keeps behaving like nobody wants to own the number.
Not if you mean it makes people suspicious in a very understandable way. If you mean the system proves collusion, no. Confusing is not the same thing as coordinated. And frustration is not evidence by itself.
Right, because one price with insurance, another with a coupon, another if the pharmacy can or can't process something, and now everybody thinks the number is made out of vibes. That's enough to make a normal person start squinting at the whole setup.
And that's where the multi-actor part matters. KFF's Medicaid brief shows how several entities can be negotiating rates and reimbursement at the same time. When everyone touches the same price, the patient sees one blur, not one decision. And that blur can feel more intentional than it is.
Which is also a lovely way to make sure nobody feels accountable. The handoff becomes the business model, and the person at the counter is left trying to reverse engineer the whole mess in real time.
Exactly. Confusion can be useful to the side that already has more leverage, because the person at the counter has to act first, while everyone else gets to hide behind process, policy, or a different company name.
So when people say, this feels scammy, they're not crazy. They're just skipping from, this is opaque, to, there must be one grand plan. And that second jump is where the wheels come off.
That's the better version of the argument. Opaque pricing can be manipulative, frustrating, and unfair without being proof of a single conspiracy. Those are different buckets, and if we mix them up, we lose the thing worth criticizing.
Okay, so what would count as enough to accuse coordination instead of just bad incentives? Because I feel like people never say where that line is, and that silence does a lot of work.
Good question. You'd want evidence that goes beyond the outcome itself. Repeated matching behavior that can't be explained by incentives alone. Direct communications, or some clear pattern showing the actors are actually acting together. Otherwise, You're just looking at the same ugly result and assuming there has to be one hidden author.
So not just the prices look stupidly similar or everybody seems to land in the same place. That's evidence that the system is converging, but not automatically that somebody ordered the convergence.
Right. Similar outcomes can come from similar incentives, especially in a market with a lot of middlemen and a lot of contract leverage. That part is annoying, but it is not the same as proof, and we should not pretend it is just because the outcome is ugly.
That distinction matters because otherwise, every bad thing becomes a secret cabal, and then you're basically just shouting at fog. It feels righteous for about 10 seconds, and then it starts dissolving the actual argument.
And once you do that, you stop seeing the real target. If the issue is that the system lets multiple middlemen profit from complexity, the critique should stay on complexity, leverage, who pays, and who absorbs the confusion.
That's the part that feels honest to me. Say the design is bad. Say it rewards opacity. Say people get worn down trying to compare prices. But don't dress that up as proof of hidden masterminds just because the outcome is gross.
Yeah, the strongest skeptical version is not everyone is innocent. It's we can explain a lot of this without inventing a conspiracy, and we should only upgrade the claim if the evidence earns it. That keeps us sharp instead of sloppy.
So the disciplined version is the system can be exploitative and still not be a cartoon plot.
Exactly. And if we keep that standard, the next question is, what would actually make the pricing clearer enough that patients aren't stuck playing detective with their own medication?
Okay, after the conspiracy break part, I think we can finally be fair to the two strongest readings. One is basically, this is a pile of old contracts, rebates, plan rules, and reimbursement layers that nobody fully understands anymore. The other is, sure, it is messy, but the mess keeps certain players comfortable because complexity protects leverage. Those are both real arguments, and if we do this right, neither one gets turned into a cartoon.
That's the clean split. The chaos version says the system got built one layer at a time, and once those layers exist, nobody wants to be the first person to eat the cleanup cost. You end up with multiple cost components, negotiated rates, rebates, and different reimbursement rules all sitting on top of each other, and every actor can point at somebody else when the patient gets confused.
And that does not sound like a mastermind in a chair rubbing his hands together. It sounds like a system that kept answering one problem with another rule until the patient is stuck at the counter trying to figure out why the price changed between the app, the plan, and the pharmacy.
But Sam, what's the fair boundary between this is a mess and people are using the mess on purpose? Because if we blur those together, we start treating every bad outcome as proof of
who gets helped by the confusion. Not everybody needs a master plan. Sometimes the cleaner explanation is that the people with leverage notice the mess works for them, and then they stop rushing to fix it.
That is the stronger, suspicious version, and I buy part of it. Complexity can protect leverage because PBMs can steer consumers, negotiate contract terms, and influence reimbursement relationships. So even if nobody designed the whole thing from scratch to be opaque, opacity can become an asset once it exists, which is a pretty ugly incentive structure.
Right, and that is where the innocent explanation starts sweating. If a system keeps making it hard for normal people to know the true price, compare options, or challenge a charge, then the "we just inherited this" story stops feeling complete. Maybe it started as structure. Maybe it stayed ugly because structure paid.
Still, the chaos explanation has teeth. The KFF material fits it pretty well. The system is layered enough that it is hard to unwind, and some of the components are compromise mechanisms, not just pure extraction. Rebates can lower plan costs and sometimes even out-of-pocket costs. So you cannot honestly say every moving part is there only to squeeze patients. Some of it is a negotiated compromise that got frozen in place.
No, and I do not want that lazy take either. If I call everything a scam, I do the exact thing I'm complaining about. I stop distinguishing between annoying, manipulative, misleading, and outright bad. The irritating part is that the system can produce some real savings and still be structured so normal people have almost no ability to see what they are buying or challenge what they are charged.
That is the part people skip. You can have something that is partly functional and still be unfair in practice. The question is whether the design asks patients to absorb all the complexity, while everyone else gets better information, better bargaining power, and a softer landing when something goes wrong.
So the suspicious version is not everybody is evil. It is more like once complexity becomes profitable, nobody with power is in a hurry to simplify it in a way that helps the person at the counter. That's a lot less cinematic, but it's also more believable and honestly more annoying because it does not give you one villain to blame.
And the chaos version still matters because it explains why the whole thing can survive without looking like a single coordinated plot. So the fair standard is simple. If a patient cannot see the true price, compare it before committing, and get a straight answer when something looks off, the design is not fair enough yet. That is the line that takes us into fixes.
Okay, if the diagnosis is structural, the practical question is simple. What would make the pharmacy counter less arbitrary for the person standing there? Not perfect, not elegant, just less weird and less punishing.
That's the right place to land. Not how do we rebuild the entire industry overnight, just what changes the experience from unpredictable to something a normal person can plan around.
Because right now, the patient is the one absorbing the confusion. The insurer, the PBM, the pharmacy, the coupon program, the benefit design, everybody gets to point somewhere else and act like that settles it.
And that's where price transparency matters, but only if it shows up early enough to affect the decision. A number you learn after the prescription is already in motion is not really transparency. It's a receipt with better branding.
So the first fix is boring, which usually means it's the right one. Make the likely price visible before the patient is committed. Not every edge case solved, just a real enough estimate that a person can compare options instead of guessing and hoping.
Exactly. And it has to be usable, not theoretically available. If the information is buried in 3 portals and a phone tree, then the system is technically disclosing something while still making the patient do homework to get it.
Joe, am I overstating it if I say the core failure is that the system keeps making the patient do the work of 5 different companies at once? Because that feels like the real insult, not just the price itself.
That's the fair version of it. The patient doesn't need to understand every contract, but they do need one answer that behaves like a real price, not something that changes depending on which entity happened to touch it last.
And there are already some reform ideas pointing in that direction. KFF's examples around prescription price negotiation suggest that when the pricing rule gets more direct, some out-of-pocket costs can come down instead of just bouncing around the system.
Right, and KFF also notes the Part D option to spread out-of-pocket costs through the year. That's not flashy, but it's exactly the kind of design change that makes the expense more predictable instead of landing all at once like a bad joke.
That timing piece matters more than people admit. A person can usually handle bad news better than surprise bad news. If you know what you're walking into, the system is still expensive, but at least it isn't also humiliating.
That's the useful distinction. Even when the dollar amount doesn't change much, predictability is a real improvement. It doesn't solve affordability by itself, but it stops the process from feeling like the counter is deciding your fate in real time.
The coupon mess is another place where the rules need to stop fighting each other. If a patient has to wonder whether a coupon helps, breaks something else, or disappears when the wrong processor touches it, then the offer is not helping them make a decision.
Cleaner coupon rules would help most when they're simple enough to understand before the prescription is already moving. That's the part people skip. Information is only useful if it arrives while there's still a choice to make. Otherwise, it's just post-game commentary.
And we're not even asking for miracles here. More usable information, earlier, with fewer hidden handoffs. If the patient can't tell where one rule ends and the next one starts, the system is asking them to navigate a process nobody bothered to explain.
That's also where simpler benefit design matters. The more layers you add, the easier it is for each layer to claim it's not responsible for the confusion. There are policy fixes aimed at reducing the incentive to make pricing harder to understand. And that's the direction that actually helps.
So if you had to make this less awful without pretending you're rebuilding healthcare from scratch, what would you actually put first? Upfront price visibility, simpler benefit design, or cleaner coupon and assistance rules?
Upfront price visibility first, because that changes the patient experience immediately. Then, benefit design that's less maze-like. And then, cleaner coupon and assistance rules so people aren't bounced between contradictory systems when they're already trying to fill a prescription.
That's the fair standard, really. The patient should be able to see a plausible price early, understand the basic rule without a decoding session, and use help without the help turning into another obstacle. If it can't do that, it's still too broken.
So, stripped of all the noise, I think the cleanest answer is this. The frustration is real, but the thing doing most of the damage is the structure. Not one random pharmacy worker or one coupon program having a bad afternoon. The system is set up so the price arrives late, in pieces, and with a bunch of other people's rules attached to it.
That's the part worth keeping. People aren't imagining it when the same prescription can feel like 3 different products depending on the insurance card, the coupon, or which pharmacy is willing to process what. That kind of experience makes normal adults start thinking the whole thing is cursed.
And that's
honestly,
because the price isn't really showing up as one price anymore. It's a chain of coverage rules, negotiated rates, coupon terms, and processing steps. Nobody outside the system has a clean view of the whole thing, which is why it feels like you need a translator just to buy a bottle of pills.
Which is a fancy way of saying the patient shows up thinking they're buying medicine, and instead they're being asked to navigate everybody else's arrangements. That's not a small inconvenience. That's the entire point of failure. Because the person who needs the drug is also the person least able to decode the bill at the counter.
And that's why I don't think the best complaint is somebody in the back room is uniquely evil. The cleaner complaint is that the design hides the real number until the moment when the customer has the least leverage. If you want to understand why people feel jerked around, that's enough on its own.
Joe, am I overstating it when I say opacity is doing a lot of the work here? Because it feels like the system doesn't just tolerate confusion. It kind of survives because confusion is doing unpaid labor for everybody else.
No, that's the useful version. Opacity makes the bad number harder to challenge, and it also makes the bad number easier to explain away after the fact. If the patient only finds out at the counter, the system has already won most of the argument. That's not proof of a conspiracy. It's proof that the structure protects itself through timing.
Right, and the background facts support that frustration. The CDC and KFF material we've leaned on basically backs up the boring but important part. Prescription pricing is variable. People do face meaningful out-of-pocket costs. And the mess is real enough that it's not just consumer paranoia doing laps around the parking lot.
Exactly. Once you admit the pain is real, you can stop arguing with the patient's nerves and start asking, who benefits from opacity? Who pays for it? And who gets to keep their hands clean because the confusion gets passed down the chain? That's the structural story here. The layers absorb the heat, while the person at the counter has to move first.
So what counts as the fair standard then? Because I don't think people need a miracle. They just need a system where the number is legible early enough that you can react before you're trapped in the little hostage negotiation with the pharmacy printer.
That's the line I would use. Tell people the real number sooner, make it clear who said it and why, and don't make the patient be the translator between the contract pile and the counter. If a pricing system can't do that, it may still be legal and still be ordinary, but it's not fair in any meaningful consumer sense.
And that's the part that keeps this from becoming generic anti-corporate noise. The complaint isn't prices exist or even businesses make money. The complaint is that the system makes ordinary people absorb confusion first and explanation later, which is basically the worst order if you're trying to sell healthcare with a straight face.
No, and that gives us a pretty solid ending. The frustration is legitimate. The structure is the real problem. And the strongest takeaway is not that every odd charge is a scam. It's that layered pricing makes fairness hard to see and harder to contest. That's the thing worth fixing.
Yeah, not pure despair, not a neat conspiracy, just a pricing machine that makes clarity expensive for the people who need it least, which is a pretty bad design. And at least now we can say what the problem actually is without dressing it up.
That wraps up today's question. Thanks for listening to Say the Question. Follow the show so you don't miss tomorrow's episode.